Welcome to the deep dive. Look, I know exactly where you are right now. You are staring down week 7 of your med-surg rotation.
Oh yeah, running on cold coffee and willpower.
Exactly. Pure, unadulterated willpower. And the looming shadow of the NCLEX is probably feeling very, very real right about now.
It's a lot. Nursing school is, it's a pressure cooker. It demands everything you have.
It really does. But you made the time to plug in and be here. And that tells us that you aren't just trying to, scrape by with a passing grade. You're actively trying to become an exceptional clinician.
Right, which is why we are here.
So today our mission is to make Chapter 25, that's the management of patients with complications from heart disease. We want to make that permanently click in your brain.
We're definitely moving past the flashcards today.
Oh, absolutely. We have a massive stack of source material covering the pathophysiology, clinical manifestations, the really complex pharmacology, and of course the essential nursing processes for heart failure and its most life-threatening complications.
And we're going to frame this entirely around the why. Because look, memorizing a list of symptoms or drug side effects might get you through a Tuesday morning quiz.
Barely.
Right, barely. But understanding the underlying physiological mechanics, that is what allows you to recognize those really subtle, quiet changes in a patient before those changes escalate into a massive decompensation.
A code blue on the floor.
Exactly. And our sources highlight a pretty sobering reality here. Cardiovascular disease remains the leading cause of death in the United States.
Number one.
It is. This isn't just a niche specialty topic reserved for the cardiac ICU.
Right. Whether you eventually land in a rural community clinic, a busy labor and delivery ward, the ED, or just a standard medical surgical floor, you are going to be caring for patients whose hearts are failing.
It's everywhere. Understanding this system is absolutely non-negotiable for safe nursing practice.
Okay, let's unpack this. Let's get straight into the cellular mechanics of what our text refers to as the vicious cycle of heart failure pathophysiology.
A vicious cycle, yeah.
And the first hurdle here is really adjusting how we define the condition itself. Because heart failure, or HF, it isn't a single isolated disease that you just catch.
No, not at all. It is a clinical syndrome.
Right. It's basically the grim final destination of a long road that's paved by other cardiovascular disorders. The heart has fundamentally just become a failing pump. It is unable to generate enough cardiac output to meet the oxygen and metabolic demands of the body's tissues.
And the underlying culprits that cause this pump failure, they are usually chronic and progressive.
Like coronary artery disease.
Exactly, CAD, where progressive atherosclerosis just starves the myocardial tissue of oxygen, which leads to ischemia and eventual infarction.
And chronic, poorly managed hypertension, too.
Oh, massive culprit. Hypertension is essentially forcing the left ventricle to pump against a brick wall of high systemic vascular resistance for years.
Decades, even.
Right. Then you have cardiomyopathies, where the actual myocardial tissue becomes diseased, abnormally thick or dangerously thin.
And valvular disorders.
Yes, valvular disorders. If the aortic valve is profoundly stenotic and stiff, or the mitral valve is floppy and regurgitant, the mechanical efficiency of the heart just plummets.
It's working so hard for so little payoff.
Exactly. Any of these conditions structurally damages the myocardium. But the fascinating and honestly tragic part of heart failure is that the initial damage isn't what ultimately kills the patient.
This is this crazy part.
It is. What destroys the failing heart is the body's own attempt to save it.
The compensatory mechanisms.
Yeah.
The body is an incredible biological machine, but in this specific context of a failing heart, it is entirely too smart for its own good.
It overreacts.
It hits the panic button. The brain senses a drop in cardiac output and interprets that drop as an immediate existential threat to survival. So the primary fixes the body deploys actually accelerate the destruction of the cardiac tissue. Let's trace the first wave of this response, the baroreceptor reflex.
Okay, picture the hemodynamics here. The left ventricle is damaged and weak, so stroke volume drops.
Makes sense.
As less blood is pushed into the systemic circulation, the blood pressure naturally falls. Now, located high up in the aortic arch and the carotid sinuses are these specialized mechanoreceptors called baroreceptors.
They measure stretch.
Right. As the stretch on the arterial walls decreases due to the low pressure, these baroreceptors decrease their firing rate to the cardiovascular control center in the medulla oblongata.
And the medulla freaks out.
Instantly. It decreases parasympathetic vagal tone and unleashes the sympathetic nervous system. The adrenal medulla is triggered to dump massive amounts of catecholamines, specifically epinephrine and norepinephrine, directly into the bloodstream.
Boom! Adrenaline rush. Those stress hormones just flood the system, seeking out the beta-1 adrenergic receptors in the heart and the alpha-1 receptors in the peripheral vasculature.
And what happens? The epinephrine binds to the heart and violently forces it to beat faster
Tachycardia.
and contract harder. Simultaneously, the peripheral blood vessels clamp down. They shunt blood away from the skin, the gastrointestinal tract, the kidneys, all trying to centralize the blood volume to keep the brain and the heart perfused.
So from the brain's perspective, the problem is temporarily solved. The blood pressure creeps back up.
But the cost to the heart is astronomical.
The heart is being whipped. Its oxygen demand skyrockets just as its supply is compromised. But the sympathetic nervous system is really only the first wave.
Right, the profound long-term damage comes from the second wave, which is triggered directly by that peripheral vasoconstriction we just talked about.
Because the sympathetic nervous system clamped down on the renal arteries.
Exactly. The kidneys experience a massive drop in blood flow, and the kidneys are highly sensitive, highly vascular organs. Deep within the nephron, at a specialized area called the macula densa, this drop in sodium delivery and fluid flow is detected.
And this is where things get really bad.
This signals the juxtaglomerular cells to release an enzyme called renin into the systemic circulation. This initiates the renin-angiotensin-aldosterone system, or the RAAS cascade.
The RAS cascade. This cascade is the absolute engine of heart failure progression. The renin travels through the blood until it encounters a plasma protein synthesized by the liver called angiotensinogen. Renin cleaves it, converting it into angiotensin I.
Now, angiotensin I is relatively biologically inactive on its own.
Right, but as the venous blood carries angiotensin I through the massive pulmonary capillary bed of the lungs, it encounters ACE.
Angiotensin converting enzyme.
Yes, ACE actually cleaves angiotensin I into angiotensin II. And angiotensin II is one of the most potent, destructive vasoconstrictors in the human body.
It is incredibly powerful. Angiotensin II binds to receptors on the smooth muscle of the vasculature systemically, causing profound vasoconstriction. This dramatically increases the afterload.
And afterload is basically the total systemic vascular resistance that the already weakened left ventricle must push against just to open the aortic valve.
It's like trying to push water through a tiny crimped straw. But angiotensin II doesn't even stop there.
No, it travels down to the adrenal cortex,
Sitting right on top of the kidneys, and stimulates the release of the mineralocorticoid hormone, aldosterone. Aldosterone targets the principal cells in the distal convoluted tubules and collecting ducts of the kidneys, commanding them to reabsorb sodium from the urine back into the blood.
And the golden rule of fluid dynamics in the body is that wherever sodium goes, water follows.
Always.
So the kidneys hold on to massive amounts of sodium, dragging liters of water right back into the vascular space. So look at what the compensatory mechanisms have achieved here.
They have given a failing, weakened pump a massively increased volume of fluid to manage.
Increasing the preload.
Right, and forced it to pump that heavy volume through tightly constricted high-pressure pipes.
Increasing the afterload.
Which is exactly why the literature refers to this as a vicious cycle. The workload on the myocardium increases exponentially. Under this relentless mechanical and hormonal stress, the architecture of the heart actually physically alters.
Ventricular remodel.
Yes. According to Laplace's law, to decrease the wall stress caused by the high pressure, the cardiac myocytes undergo hypertrophy. The heart muscle physically thickens.
But this isn't good, healthy muscle.
No, this new muscle is abnormal. It is stiff, fibrotic, highly non-compliant. As the volume overload continues, the chambers dilate and stretch out like an old balloon that's been blown up too many times.
And on top of that, the toxic soup of high-circulating catecholamines and angiotensin II triggers apoptosis.
Programmed cell death.
The cardiac cells literally begin to commit suicide, dropping out of the matrix and leaving the remaining exhausted cells to shoulder an even heavier burden. I always visualize this pathophysiology using the analogy of a horse and a cart.
I love this analogy.
Think of the failing heart as a severely exhausted, aging horse trying to pull a heavy cart up a steep hill. The sympathetic nervous system and the RAAS cascade are the rider. When the horse slows down, the rider doesn't take weight out of the cart. The rider pulls out a whip.
Epinephrine is the whip.
Exactly, forcing the horse to work harder. Angiotensin II and aldosterone are the equivalent of the rider throwing heavy sandbags into the back of the cart, increasing the load. For a short time, the whipping might force the horse to speed up. But eventually, under the crushing weight and the relentless whipping, that horse is going to collapse.
Now, the body does attempt to deploy a counter-regulatory mechanism against this cascade, utilizing the natriuretic peptides.
The AMP and BNP.
Right. As the massive volume of retained fluid stretches the walls of the atria and the ventricles, the myocardial cells release atrial natriuretic peptide, or ANP,
Yeah.
and B-type natriuretic peptide, or BMP. These peptides attempt to induce vasodilation and signal the kidneys to excrete sodium and water.
They're desperately trying to offload the fluid.
They are. But in chronic heart failure, the RAAS cascade and the sympathetic nervous system are simply too dominant. The natriuretic peptides are entirely overwhelmed, and the fluid just continues to accumulate.
So we understand the microscopic warfare happening inside the cardiovascular system. How do we measure the collateral damage? Let's look at the classifications and the clinical manifestations. We have to quantify how badly the pump is failing.
And the primary metric for that is the ejection fraction, or EF.
The mechanics of the ejection fraction are pretty straightforward but critical to grasp. During diastole, the relaxation phase, the left ventricle fills with a specific volume of blood. This is the end diastolic volume.
When the ventricle contracts during systole, it doesn't wring itself completely dry.
It's not a sponge.
Exactly. It only ejects a percentage of that total volume. That percentage is the ejection fraction. In a healthy, well-conditioned adult, an expected EF is anywhere between 55% and 65%.
So the diagnostic categories are defined by where the patient's EF falls on that spectrum. The most classic presentation is heart failure with reduced ejection fraction, or HREF.
Clinically, we often refer to this as systolic heart failure.
This is diagnosed when the EF drops to 40% or lower. The left ventricle is boggy, dilated, and the muscle is simply too weak to generate a forceful contraction. The forward flow of blood is severely compromised.
The clinical contrast to that is heart failure with preserved ejection fraction, or HFpEF. We historically call this diastolic heart failure. In these patients, the echocardiogram shows an ejection fraction of 50% or greater.
Which sounds normal on paper.
On paper, the percentage looks great, but the pathology lies in the relaxation phase. The left ventricular wall has undergone such severe hypertrophy that it is thick, stiff, and fibrous. It cannot relax and expand to fill with blood.
So while it might be successfully ejecting 60% of the blood it holds, the absolute volume it is capable of holding is dangerously low.
Exactly. The patient still exhibits profound symptoms of poor cardiac output because the total stroke volume is inadequate.
The sources also note a newly defined intermediate category called HFmREF heart failure with mid-range ejection fraction.
That's where the EF hovers in the gray zone between 40% and 49%.
But when we step away from the echocardiogram report and actually walk into the patient's room, we categorize their physical symptoms based on the hydrodynamics of the failure. Which side of the heart is failing and where is the fluid backing up?
Let's start with the left side.
The simplest heuristic to anchor your assessment is left equals lungs.
Left equals lungs. The left ventricle is the powerhouse of systemic circulation. When it fails to push adequate volume forward through the aortic valve, the blood doesn't just disappear, the pressure backs up.
It retrograde flows.
Right, from the left ventricle, back through the mitral valve into the left atrium, and then pushes backward into the four pulmonary veins. This creates massive hydrostatic pressure within the pulmonary capillary bed.
The pressure becomes so great that it physically forces fluid out of the vasculature, across the respiratory membrane, and into the interstitial spaces and the alveoli of the lungs.
The patient is slowly drowning from the inside out.
Your assessment findings will be entirely respiratory focused. The patient will report profound dyspnea on exertion. Walking to the bathroom feels like running a marathon.
You will see orthopnea. You'll walk into the room and notice they have the head of the bed cranked up, or they're propped up on 3 pillows.
Because lying flat redistributes blood from their lower extremities back to the heart, overwhelming the left ventricle and instantly flooding their lungs.
They may describe paroxysmal nocturnal dyspnea, or PND, where they wake up in a total panic at 2 a.m., gasping for air and feeling a true sense of impending doom.
When you auscultate their lung fields, you are going to hear the fluid. You will hear bibasilar crackles, a fine popping sound at the bases of the lungs that is caused by the sudden opening of fluid-filled airways.
A key assessment parameter here is that these crackles do not clear when you ask the patient to cough.
Right, because the fluid isn't sitting in the large bronchi. It is trapped deep in the alveolar spaces.
You might also auscultate an S3 ventricular gallop. Instead of a crisp lub-dub, you hear lub-dub-dub. That third heart sound is the acoustic shockwave of blood rushing into a highly non-compliant, overfilled ventricle during early diastole.
There is a specific symptom associated with left-sided failure that beautifully illustrates the connection between hemodynamics and the patient experience: nocturia.
Oh, this is a huge quality of life issue.
Why is the heart failure patient waking up 5 times a night to urinate? During the day, while they are upright and moving, the failing heart cannot generate enough pressure to adequately perfuse the kidneys. The RAS system is highly active, holding on to fluid, and daytime urine output is scant.
But observe what happens when they finally lie down to go to sleep. The physical demand on the body decreases. Furthermore, the dependent fluid that has been pooling in their legs all day due to gravity is suddenly level with the heart.
That fluid shifts back into the intravascular space, increasing venous return.
The resting heart manages to pump this return volume effectively enough to finally perfuse the renal arteries. The kidneys, starved for blood flow all day, suddenly wake up.
They begin rapidly filtering the blood and producing urine. The patient's sleep architecture is entirely destroyed because their kidneys are doing a full day's worth of diuresis in the middle of the night.
It is a miserable cycle of exhaustion.
It really is. Now, let's contrast that with right-sided heart failure. If left equals lungs, right equals the rest of the body.
The right ventricle's sole job is to accept deoxygenated venous blood and pump it against the relatively low-pressure system of the lungs.
When the right ventricle fails, the forward flow stalls, and the massive volume of venous blood backs up into the systemic circulation.
The entire venous network becomes engorged and highly pressurized. When you assess the patient, the first and most proximal sign is often visible right in the neck.
Jugular venous distension, or JVD.
The internal jugular vein acts as a direct manometer for the pressure in the right atrium. Below the diaphragm, the inferior vena cava backs up into the hepatic veins. The liver becomes violently engorged with blood, stretching Glissen's capsule and causing hepatomegaly, a severely enlarged, tender liver.
As the portal hypertension worsens, the hydrostatic pressure forces protein-rich fluid out of the hepatic vessels and directly into the peritoneal cavity,
Creating massive abdominal ascites.
the patient's abdomen will be distended, taut, and visibly swollen. This increased intra-abdominal pressure compresses the stomach and the intestines. The bowel walls themselves become edematous.
Because of this, the patient will report profound gastrointestinal distress. They will have anorexia, nausea, early satiety. They literally feel too bloated and sick to take more than 2 bites of food.
Leading to cardiac cachexia, severe muscle wasting hidden beneath the fluid weight.
And then you have the classic hallmark of right-sided failure, dependent pitting edema.
The hydrostatic pressure in the peripheral capillaries forces fluid into the subcutaneous tissues. Because of gravity, this fluid pools in the lowest dependent areas.
The feet, the ankles, the vertebral area, or the sacrum if the patient is bedbound.
The diagnostic technique requires you to press your thumb firmly over the bony prominence of the ankle for a few seconds. When you release the pressure, you leave a deep, visible indentation that takes significant time to refill. The tissue feels like memory foam.
Our source text provides a clinical statistic here that should alter how you view fluid balance. A patient can retain upwards of 10 pounds of fluid, which equates to roughly 4.5 liters of pure water, before pitting edema even becomes visually obvious to the naked eye.
10 pounds. The patient is carrying a massive hidden reservoir of water weight before their ankles even start to swell.
It is vital to recognize that the right side of the heart rarely fails in isolation, unless the patient has a specific lung pathology like pulmonary hypertension known as cor pulmonale.
Far more commonly, left-sided heart failure is the direct cause of right-sided heart failure.
The left ventricle fails, the pressure backs up into the pulmonary capillary bed, and suddenly the right ventricle is forced to pump against massive pulmonary hypertension. The right ventricle, which is thin-walled and not designed for high-pressure work, quickly dilates and fails.
When both the left and right sides are failing, manifesting with both pulmonary and systemic symptoms, we use the broad term systemic congestive heart failure.
To confirm these clinical suspicions, the provider will order a battery of diagnostic tests. We already discussed the echocardiogram, which is the gold standard imaging modality to determine the ejection fraction and visualize the structural integrity of the valves and chambers.
A chest X-ray will be ordered to identify cardiomegaly, an enlarged cardiac silhouette, and to look for the classic hazy white infiltrates of pulmonary edema.
A 12-lead ECG is mandatory to identify dysrhythmias, conduction delays, or evidence of a prior myocardial infarction that may have precipitated the failure.
But the laboratory value that demands your closest attention as a nurse is the BNP level.
We discussed how B-type natriuretic peptide is released by the ventricles when they are subjected to excessive stretch and volume overload. This makes the BNP assay an incredibly sensitive biomarker for myocardial wall stress.
If a patient presents to the emergency department with severe dyspnea, it can be clinically difficult to differentiate between a severe COPD exacerbation and an acute heart failure decompensation.
The BNP level cuts through the ambiguity. A significantly elevated or rapidly trending BNP is a definitive indicator of high cardiac filling pressures and confirms that the dyspnea is cardiogenic in origin.
Okay, we understand the pathology, we recognize the clinical presentation, and we've reviewed the diagnostics. Now, how do we actually intervene? We transition into the pharmacopoeia.
The medical management of heart failure is intricate, heavily reliant on polypharmacy, and demands rigorous nursing surveillance.
The entire pharmacological strategy is aimed at dismantling that vicious cycle we outlined earlier. The most immediate priority is usually relieving the severe congestive symptoms.
Which means we deploy the diuretics to pull the fluid off. Diuretics are the frontline agents for fluid management, and you must understand the different classes because they act on different segments of the nephron.
The heavy artillery are the loop diuretics, primarily furosemide.
These agents act directly on the thick ascending limb of the loop of Henle, powerfully inhibiting the sodium-potassium chloride symporter. They force the kidneys to dump massive quantities of sodium and, consequently, massive volumes of water.
For a patient drowning in pulmonary edema, IV furosemide is a rapid, life-saving intervention.
Then we have the thiazide diuretics, like medelazone, which work a bit further down the plumbing in the distal convoluted tubule. They are less potent than loop diuretics, but are often used in combination to achieve a synergistic diuresis.
And finally, we have the aldosterone antagonists like spironolactone. Remember our discussion of the RAAS cascade? Spironolactone directly blocks the mineralocorticoid receptors, preventing aldosterone from forcing the reabsorption of sodium.
The administration of diuretics carries massive nursing responsibilities. You are aggressively manipulating the patient's intravascular volume and electrolyte balance. As you diurese the patient, their blood pressure will drop.
You must monitor for orthostatic hypotension. The patient who felt fine sitting in bed may stand up to use the commode, experience a sudden drop in cerebral perfusion, and syncopize. Fall precautions are mandatory.
Furthermore, you must track their fluid status with obsessive precision.
This means strict intake and output, or I and O, tracking. And let's be honest about the reality of the floor. This is incredibly difficult. You have to educate the patient and the family that every sip of water, every cup of ice chips, and every ounce of soup must be recorded.
You have to explain to the well-meaning family member why they absolutely cannot empty the patient's urinal down the toilet before you measure it.
Every milliliter matters. But even more accurate than I and O's is the strict daily weight. A liter of fluid weighs exactly 1 kilogram, or 2.2 pounds. The daily weight is the most sensitive, objective data point regarding fluid retention or loss.
Beyond volume depletion, diuretics trigger dangerous electrolyte shifts, specifically involving potassium. Loop diuretics like furosemide and thiazides like medelazone are potassium wasting.
As the massive volume of fluid flows through the distal tubules, potassium is dragged out into the urine. Profound hypokalemia can induce lethal cardiac dysrhythmias. You will almost certainly be administering potassium chloride supplements to these patients.
But you have to critically evaluate the MAR because spironolactone operates entirely differently. It is a potassium-sparing diuretic.
By blocking aldosterone, it stops the sodium for potassium exchange in the distal tubule. The body dumps sodium but aggressively holds onto potassium.
If a patient on spironolactone is given a potassium supplement, or if their renal function declines, they can develop severe hyperkalemia, which will cause peaked T waves on the ECG and can rapidly progress to ventricular fibrillation.
You cannot simply hand a patient a diuretic pill. You must actively correlate the medication with their morning basic metabolic panel.
While diuretics are essential for symptom relief, they do not halt the progression of the disease. To actually alter the trajectory of heart failure and improve long-term survival, we have to chemically sever the RAAS cascade.
This brings us to the angiotensin system blockers, which are the foundational cornerstone of modern heart failure therapy.
The vanguard of this class are the ACE inhibitors, identifiable by their uptral suffix, like lisinopril or enalapril.
By inhibiting the angiotensin-converting enzyme in the lungs, we completely halt the conversion of angiotensin I to the destructive angiotensin II. Suddenly, the systemic vasoconstriction stops. The peripheral vessels dilate, causing a massive drop in afterload.
The heart can finally push blood forward against a relaxed vascular bed. Furthermore, without angiotensin II, aldosterone release is halted, so the kidneys stop hoarding sodium and water. The workload on the myocardium plummets.
ACE inhibitors have been proven to literally reverse the pathological ventricular remodeling we discussed earlier. They are life-extending medications.
But they carry a very specific, high-yield side effect profile. The ACE enzyme doesn't just convert angiotensin, it is also responsible for degrading a peptide called bradykinin in the pulmonary tissues.
When you inhibit ACE, bradykinin accumulates in the lungs. In roughly 10 to 20% of patients, this bradykinin buildup causes a persistent, dry, hacking cough.
It is aggravating, it interrupts their sleep, and it will not respond to over-the-counter antitussives.
And in rare but severe cases, that bradykinin accumulation can trigger angioedema, a rapid, localized swelling of the dermis and subcutaneous tissues, particularly around the face, lips, tongue, and airway.
It is an immediate life-threatening emergency that requires airway management. If a patient develops the cough or experiences any degree of angioedema, the provider will immediately discontinue the ACE inhibitor and transition them to an ARB.
An angiotensin II receptor blocker.
ARBs, which end in these sartan suffix like valsartan or losartan, achieve the exact same hemodynamic goals, but through a different mechanism. They bypass the ACE enzyme entirely and simply act as competitive antagonists directly at the angiotensin II receptor sites on the blood vessels and the adrenal glands.
Because they don't inhibit the ACE enzyme, bradykinin is broken down normally, meaning there is no cough and a vastly reduced risk of angioedema.
However, the pharmacology landscape is shifting, and our sources heavily emphasize a newer, remarkably effective class of medications for patients with HFrEF, the ARNANs, or angiotensin receptor neprilysin inhibitors.
The primary drug in this class is sacubitril valsartan. This medication is a brilliantly engineered two-pronged attack.
The valsartan component is the ARB we just discussed, providing the crucial vasodilation and afterload reduction. The sacubitril component is a neprilysin inhibitor.
Neprilysin is the enzyme responsible for degrading the body's natriuretic peptides, BNP and ANP.
By inhibiting neprilysin, sacubitril ensures that those helpful natriuretic peptides remain in the bloodstream much longer, actively promoting natural diuresis and further vasodilation. It is a highly synergistic combination that has become a first-line therapy.
But there is a massive, incredibly dangerous nursing alert associated with RNS. Because neprilysin inhibition also has a mild effect on bradykinin breakdown, combining an ARNI with an ACE inhibitor creates a profoundly dangerous compounding effect that skyrockets the risk of severe angioedema.
You absolutely cannot administer an ARNI and an ACE inhibitor together. In fact, if a patient is transitioning from an ACE inhibitor to an ARNI, you must enforce a strict 36-hour washout period.
The ACE inhibitor must be entirely out of their system before that first dose of sacubitril valsartan is given.
Next in our pharmacological arsenal are the beta blockers, agents like carvedilol, metoprolol, or bisoprolol.
The rationale here initially seems entirely counterintuitive. We have a failing heart that is struggling to pump, and we are going to give a medication that explicitly slows the heart rate and decreases myocardial contractility. Why would we intentionally depress cardiac function?
Because we have to protect the heart from the toxic effects of its own sympathetic nervous system. The chronic barrage of epinephrine is literally working the myocardium to death.
Beta blockers act as a shield. By antagonizing the beta-1 adrenergic receptors, they block the catecholamines. The heart rate slows down, diastole is prolonged, allowing for better coronary artery perfusion and ventricular filling, and the myocardial oxygen demand drops significantly.
Over time, shielding the heart from this adrenaline toxicity allows the damaged myocytes to heal and actually upregulates the beta receptors, improving overall contractility in the long run.
But the initiation of beta blocker therapy requires masterful patient education. When you first introduce a beta blocker to a heart that has been relying on high sympathetic drive to maintain cardiac output, the output is going to drop.
For the first few weeks, the patient is going to feel demonstrably worse. They will experience profound fatigue, dizziness, and a sense of heavy lethargy. They will look at the medication bottle and assume the drug is harming them.
You must proactively educate them that this initial decompensation is an expected part of the process. The provider will start them on a microscopic dose and titrate it upward agonizingly slowly over weeks or months. If they can endure the initial fatigue, the long-term mortality benefits are staggering.
We also need to discuss digitalis, specifically digoxin. Decades ago, digoxin was the undisputed king of heart failure management.
It is a cardiac glycoside that inhibits the sodium-potassium ATPase pump in the myocardial cells. This inhibition ultimately leads to an accumulation of intracellular calcium, which binds to the contractile proteins and creates a powerful positive inotropic effect. The heart squeezes much harder.
Simultaneously, it enhances vagal tone, slowing the heart rate, a stronger, slower beat.
However, digoxin has fallen out of favor as a first-line agent because its therapeutic window is perilously narrow. The margin between a helpful dose and a toxic dose is razor thin.
Digoxin toxicity is a classic high-yield clinical scenario. You must be hypervigilant for the early signs: profound anorexia, nausea, and vomiting.
Neurologically, they may develop sudden confusion or classic visual disturbances, reporting that everything has a yellow-green halo or that the lights are blurring.
Cardiac-wise, it can trigger severe bradycardia or virtually any type of lethal dysrhythmia.
And here's where you synthesize your pharmacological knowledge. You must connect digoxin to potassium. Digoxin and potassium actively compete for the exact same binding sites on the sodium-potassium ATPase pump.
If the patient is hypokalemic, perhaps because they are taking a massive dose of furosemide and skipping their potassium supplement, there is no potassium to compete with the digoxin.
The digoxin binds unopposed, its effects are massively amplified, and the patient plunges directly into digitalis toxicity. You must know your patient's potassium level before administering digoxin.
The final category of medications covered in the sources are the continuous intravenous inotropes, such as milrinone, dopamine, or dobutamine.
These are strictly ICU-level medications. They are reserved for patients in profound, acute cardiogenic shock who are completely refractory to standard oral therapies.
These drugs aggressively stimulate the myocardial receptors, or inhibit phosphodiesterase, to artificially force the heart to contract with massive force. They will keep a dying patient alive, serving as a bridge to a heart transplant or a mechanical assist device, but they force the myocardium to consume massive amounts of oxygen and are highly arrhythmogenic. They are rescue therapies, not a cure.
That covers the pharmacological theory. Now let's step away from the medication cart and step up to the bedside. We need to explore the nursing process, the physical assessment, and the actual human experience of managing this disease.
Your physical assessment of the heart failure patient must be incredibly disciplined. You are essentially acting as a human fluid status monitor.
When auscultating lung sounds, you aren't just doing a quick sweep. You are listening meticulously at the posterior bases for the fine crackles that herald the onset of pulmonary edema.
When assessing for JVD, precision matters. The patient must be positioned at exactly a 45-degree angle with their head turned slightly away from you, using tangential lighting to identify the pulsation of the internal jugular vein.
You are palpating peripheral pulses, assessing not just presence, but the amplitude and volume. You are checking capillary refill and skin temperature to assess the adequacy of peripheral perfusion.
Cool, pale, clammy skin means the sympathetic nervous system is shunting blood away from the extremities. And, as we emphasized earlier, you are policing the fluid balance.
The intake and output must be exact. You are looking for oliguria defined clinically as a urine output of less than 0.5 milliliters per kilogram per hour.
If the output drops to that level, the kidneys are screaming that they're not being perfused. Anuria, which is less than 50 milliliters in a 24-hour period, is a critical emergency indicating impending renal failure.
But I and O's are notoriously flawed due to human error. That brings us back to the absolute supremacy of the daily weight. This requires a rigid protocol.
The patient must be weighed at the exact same time every morning, usually right after they void, wearing the exact same type of hospital gown, utilizing the exact same calibrated scale.
You are trending these numbers daily. The clinical red line is a weight gain of 2 to 3 pounds in a single 24-hour period, or a cumulative gain of 5 pounds over a week.
If you see that 3-pound jump, you do not wait to see what happens tomorrow. You notify the provider immediately because that patient is retaining roughly 1.5 liters of fluid and is actively decompensating. Their diuretic dose needs to be adjusted today.
Beyond the medical interventions, we must focus on lifestyle modifications, specifically diet and activity. The dietary cornerstone is a strict sodium restriction, typically capped at 2 grams or 2,000 milligrams per day.
Patient education here is paramount, because simply telling a patient to stop using the salt shaker is entirely insufficient. Only a fraction of dietary sodium comes from table salt.
The vast majority of sodium is hidden in processed foods, canned goods, and preservatives. The text provides a brilliant teaching example that you can use with your patients. If you take a standard serving of potato chips and compare it to a single cup of canned cream of mushroom soup, the canned soup actually contains significantly more sodium than the salty chips.
You have to sit down with the patient and literally teach them how to read a nutrition facts panel. You have to discuss strategies for flavoring food with herbs and spices instead of salt.
And if they are placed on a fluid restriction, which is common in advanced stages, you have to help them manage the intense, gnawing thirst. Providing ice chips, sugar-free hard candies, or frequent oral care can help mitigate the misery of being restricted to 1.5 liters of fluid a day.
Regarding physical activity, the clinical paradigm has shifted radically. Decades ago, the standard medical advice for heart failure was strict, prolonged bed rest. The theory was that resting the skeletal muscles would decrease the metabolic demand on the heart.
We now possess the data to know that this approach is disastrous. Prolonged immobility leads to rapid, severe physical deconditioning. The skeletal muscles atrophy, the cardiovascular system loses its adaptive tone, and the risk of deep vein thrombosis and pressure injuries skyrockets.
The modern approach relies on activity pacing and cardiac rehabilitation. We want the patient out of bed and moving, but the activity must be meticulously balanced with adequate rest periods.
You help the patient structure their daily routines to conserve energy. Instead of standing at the bathroom sink to shave and brush their teeth, you provide a stool so they can sit. They learn to break up their chores, resting after folding a single load of laundry rather than trying to clean the entire house in an afternoon.
This complex web of dietary rules, activity modifications, fluid restrictions, and polypharmacy brings us to a critical junction in patient care: adherence. We expect these patients to radically alter their entire lives, swallow a handful of pills that make them urinate constantly, restrict the foods they love, and weigh themselves religiously.
It is an overwhelming cognitive and psychological burden. This reality is powerfully illustrated in a nursing research profile featured in our text, focusing on a 2020 study by Dr. Mraz regarding the psychology of medication adherence.
The baseline statistic is staggering. Upwards of 50% of heart failure patients do not take their medications exactly as prescribed.
The immediate reflexive assumption from the clinical team is often dismissive. We assume the patient is simply forgetful, or that they lack the financial resources to fill the prescriptions.
But Dr. Mraz conducted a qualitative study, sitting down and interviewing older adults with heart failure to understand the why behind their actions.
The qualitative findings completely subvert the clinical narrative. Dr. Mraz discovered that in this population, non-adherence was rarely born of forgetfulness or financial strain. It was a highly deliberate, calculated choice.
These older adults were actively choosing to self-adjust their medication dosages, skipping pills on certain days or cutting their doses in half.
Let's contextualize this. Imagine an 80-year-old patient. Let's call him Thomas. Thomas knows that if he takes his massive morning dose of furosemide, he is going to be tethered to his bathroom for the next 4 hours.
But today is his grandson's Little League baseball game.
So Thomas makes a calculated decision to skip his morning diuretics so he can sit in the bleachers without experiencing urinary incontinence.
Or perhaps the beta blocker makes him so dizzy he's terrified of falling down his stairs, so he cuts the pill in half.
Thomas isn't trying to be defiant. He is attempting to manage the severe side effects of the pharmacology to preserve a sliver of his quality of life.
The study revealed something even more profound. These patients rarely discuss these side effects with their healthcare team because they perceive their nurses and doctors as being too busy to listen to their nuanced concerns.
They felt rushed during their appointments. Therefore, they didn't view their actions as non-adherence. They viewed their independent medication adjustments as a necessary form of active self-care. They were trying to take control of an uncontrollable disease.
This is where you, as the nurse at the bedside, wield incredible power. The simple act of slowing down, pulling up a chair, and actively listening is a potent clinical intervention.
When you are doing discharge teaching, you cannot simply hand Thomas a stack of printed papers, ask, "Do you have any questions?" and walk out. You must utilize the teach-back method.
You ask Thomas, when you wake up tomorrow morning, how exactly are you going to take your water fluid? What are you going to do if you feel too dizzy to stand up?
By validating his reality and problem-solving with him, perhaps suggesting he take the diuretic in the early afternoon on game days, you build a therapeutic alliance. Empathy is what actually keeps patients out of the hospital.
But despite the most empathetic care and the most optimized medical regimen, The compensatory mechanisms eventually fail entirely. The disease trajectory is ultimately downward.
We must now confront the high-stakes, rapid-sequence emergencies covered in Section 5. Let's begin with the acute decompensation of the left ventricle. Acute pulmonary edema, clinically referred to as flash pulmonary edema.
This is one of the most terrifying clinical scenarios you will ever witness. The left ventricle suddenly and catastrophically fails. It can no longer pump blood forward into the aorta.
The enormous volume of blood returning from the right side of the heart violently backs up into the pulmonary circulation. The hydrostatic pressure within the fragile pulmonary capillaries spikes so rapidly and so intensely that a massive volume of fluid is instantly forced across the respiratory membrane, completely flooding the alveolar sacs.
The patient transitions from being stable to fighting for their life in a matter of minutes. The clinical presentation is unmistakable. Because the alveoli are filled with fluid, gas exchange ceases.
The patient becomes profoundly hypoxic. They will sit bolt upright in bed, thrashing, restless, and paralyzed by the sheer terror of suffocation. They will be tachypneic, their respiratory rate rocketing into the 30s or 40s.
Their sympathetic nervous system goes into overdrive, causing massive diaphoresis. They will be drenched in cold, clammy sweat.
And then there is the hallmark, undeniable sign of flash pulmonary edema, the cough. It is an incessant, bubbling cough that produces copious amounts of pink, frothy, foamy sputum.
The extreme hydrostatic pressure doesn't just push fluid into the alveoli. It actually causes the pulmonary capillaries to rupture, leaking red blood cells into the fluid.
The rapid breathing whips the fluid, air, and blood into a pink foam that literally bubbles out of the patient's airway.
Your response must be instantaneous and aggressive. You never leave a patient in acute respiratory distress alone. You hit the call bell, you activate the rapid response team, and you immediately alter their hemodynamics using positioning.
You sit the patient straight up at a 90-degree angle, and if the bed allows, you have them dangle their legs over the side. This utilizes gravity to trap venous blood in the lower extremities, rapidly decreasing the venous return, the preload, to the right side of the heart.
Less blood returning to the heart means less blood being forcibly shoved into the already flooded pulmonary vascular bed.
Simultaneously, you are attacking the hypoxia. You apply high-flow oxygen via a non-rebreather mask. However, oxygen alone often isn't enough because the fluid is physically blocking the gas exchange.
You must anticipate the need for non-invasive positive pressure ventilation, such as CPAP or BiPAP.
These machines force high-pressure air into the lungs during inspiration and maintain positive pressure during expiration, physically pushing the fluid out of the alveoli and back into the capillaries, recruiting collapsed airways.
While the respiratory therapist manages the airway, the medical team will aggressively attack the fluid overload and the vascular resistance pharmacologically. You will push a massive dose of intravenous furosemide to initiate rapid diuresis.
To rapidly decrease the afterload and preload, intravenous vasodilators, most commonly nitroglycerin, are administered. Nitroglycerin massively dilates the venous system, pulling blood away from the lungs and giving the left ventricle a desperately needed break.
It is a highly coordinated, high-stress resuscitation to save the patient's airway and restore forward flow.
While flash pulmonary edema is an internal failure of the pump, there is another critical complication that restricts the pump from the outside: pericardial effusion, leading to cardiac tamponade.
The heart is encased in a tough, fibrous sac called the pericardium. Normally, there are a few milliliters of serious fluid in the pericardial space to provide friction-free lubrication during contractions.
But in advanced heart failure, or secondary to trauma, infection, or malignancy, fluid can aggressively accumulate within that sac.
Because the outer layer of the pericardium is fibrous and non-compliant, it does not stretch. As the volume of the effusion increases, the pressure within the pericardial space skyrockets.
This pressure has nowhere to go but inward, compressing the myocardium. The right ventricle, having much thinner walls than the left, collapses under the pressure first.
When the compression becomes so severe that the ventricles are physically crushed and can no longer expand during diastole to fill with blood, the patient is in cardiac tamponade.
Without ventricular filling, cardiac output drops to zero. The clinical manifestations are classically described by Beck's triad. First, you will observe prominent jugular venous distension.
Because the right atrium and ventricle are crushed shut, the venous blood returning from the systemic circulation hits a roadblock and backs up massively into the jugular veins.
Second, you will see profound hypotension. The ventricles aren't filling, so stroke volume collapses and blood pressure plummets.
Third, when you attempt to auscultate the apical pulse, The heart sounds will be dramatically muffled or distant because you are trying to listen through a thick wall of pressurized fluid.
The diagnostic assessment for tamponade includes monitoring for a fascinating and highly specific hemodynamic phenomenon known as pulsus paradoxus. To understand this, we have to look at the physics of ventricular interdependence.
Normally, when you take a deep breath in, the negative intrathoracic pressure pulls more venous blood into the right side of the heart. The right ventricle expands slightly, causing a microscopic drop in left ventricular filling, resulting in a tiny, clinically insignificant drop in systolic blood pressure during inspiration.
But in tamponade, the entire heart is trapped inside a rigid, pressurized fluid jacket. When the patient takes a breath, the increased venous return still flows into the right ventricle.
But because the outer wall of the right ventricle is pressed hard against the unyielding pericardial fluid, the right ventricle cannot expand outward. It has nowhere to go but inward.
The pressure violently pushes the interventricular septum over into the left ventricle. The sudden, severe bowing of the septum cuts off left ventricular filling completely for a split second, causing a massive, measurable drop in the systolic blood pressure. Specifically, a drop of more than 10 millimeters of mercury during inspiration. That is pulsus paradoxus.
Tamponade is a mechanical plumbing problem, and it requires an immediate mechanical solution. The physician will urgently perform a pericardiocentesis. Using echocardiography for guidance, a long needle is inserted through the chest wall into the pericardial space to aspirate the fluid and instantly relieve the pressure.
If the effusion is recurrent or malignant, a cardiothoracic surgeon may perform a pericardiotomy, creating a permanent pericardial window by excising a portion of the pericardium, allowing the fluid to continuously drain into the pleural space or lymphatic system.
But what happens when the heart fails entirely? When the electrical system descends into chaos, or the mechanical pump simply stops?
This brings us to the ultimate catastrophic medical emergency, cardiac arrest, the code blue.
Cardiac arrest is the abrupt, total cessation of effective cardiac output. Within seconds, the lack of cerebral perfusion causes the patient to lose consciousness.
They will have no palpable central pulse, their blood pressure is unmeasurable, and they will rapidly become apneic, though you may initially observe agonal, ineffective gasping as the brainstem dies.
The underlying rhythm on the monitor could be ventricular fibrillation, which is a chaotic, quivering myocardium, or pulseless ventricular tachycardia, where the heart is beating so fast it cannot fill, or asystole, flatline, complete electrical silence, or pulseless electrical activity, or PEA, where the monitor shows a beautiful organized rhythm, but the heart muscle itself is mechanically dead and not contracting.
Your response as a bedside nurse must be an instantaneous, reflexive execution of the American Heart Association's basic and advanced cardiovascular life support protocols.
You walk into the room, confirm unresponsiveness, and check the carotid pulse for no more than 10 seconds.
If there is no pulse, you smash the code button, call for help, drop the head of the bed flat, and initiate high-quality cardiopulmonary resuscitation. In that moment, your hands become the patient's heart. You are responsible for artificially perfusing their brain.
The physics of high-quality CPR dictates survival. You must place the heel of your hand on the lower half of the sternum and compress hard and fast.
The rate must be between 100 and 120 compressions per minute. You must compress the chest down at least 2 inches to physically squeeze the heart between the sternum and the spine, forcing blood out into the aorta.
But the relaxation phase is arguably even more critical. You must allow for full, complete chest recoil between every single compression. You have to take all of your body weight off the chest.
Why? Because the coronary arteries, which feed the heart muscle itself, only fill with blood during the relaxation phase of diastole.
If you lean on the chest, the intrathoracic pressure remains high, the coronary arteries cannot fill, and the heart remains ischemic. And because delivering that caliber of physical force is exhausting, the AHA mandates that compressors rotate every 2 minutes.
Do not let your adrenaline or your ego convince you to keep going. As you fatigue, your compressions become shallow and the patient's brain dies.
While you are performing compressions, the code team arrives with the crash card. If the rhythm analysis reveals ventricular fibrillation or pulseless ventricular tachycardia, the immediate priority is defibrillation.
The goal is to deliver a massive electrical shock within the first 2 minutes of the arrest. The shock does not restart the heart. It completely depolarizes the entire myocardium simultaneously, stopping all chaotic electrical activity, hoping that the heart's natural pacemaker, the SA node, will wake up and resume a normal organized rhythm.
Simultaneously, the team is securing the airway, establishing intraosseous or intravenous access, and administering pharmacology. The primary vasopressor in a code is epinephrine. We administer 1 milligram every 3 to 5 minutes.
Epinephrine agonizes the alpha-1 receptors, causing massive peripheral vasoconstriction. This artificially spikes the aortic diastolic pressure, which forcefully shunts whatever blood you are circulating via CPR directly into the coronary arteries and up into the cerebral vasculature.
If the patient is in refractory VFib that is not responding to defibrillation, we will push an antiarrhythmic like amiodarone to chemically stabilize the cardiac tissue membranes.
If the resuscitation is successful, if the team achieves return of spontaneous circulation, or ROSC, and the patient regains a palpable pulse, the battle is far from over. The brain has just suffered a massive hypoxic insult.
When the blood flow is suddenly restored, it paradoxically triggers a massive inflammatory cascade known as reperfusion injury, which causes severe cerebral edema and cell death. To mitigate this neurological damage, the sources detail the immediate implementation of targeted temperature management, or TTM.
TTM, previously known as therapeutic hypothermia, involves using specialized cooling blankets or intravascular catheters to rapidly drop the comatose patient's core body temperature to a specific target between 32 and 36 degrees Celsius and maintaining that hypothermic state for 24 hours.
By cooling the brain, we drastically reduce its metabolic demand for oxygen, suppress the inflammatory cascades, and significantly improve the odds that the patient will wake up with intact neurological function.
Take a moment to process the sheer volume of clinical knowledge we have traversed in this hour. We began at the microscopic level, tracing how the RAS cascade and neurohormonal toxicity drive ventricular remodeling and cellular apoptosis.
We explored the hemodynamics of ejection fractions and how a failing left ventricle floods the alveoli while a failing right ventricle engorges the liver and the peripheral tissues.
We unpacked a complex pharmacopoeia, from the potassium-wasting diuresis of furosemide to the bradykinin-induced cough of ACE inhibitors and the life-saving shield of beta blockers.
We elevated the nursing process, moving beyond daily weights to understanding the profound psychological burdens of adherence, recognizing that active listening and empathy are just as vital to survival as the medications themselves.
And finally, we confronted the ultimate clinical crucible, navigating the rapid interventions required for flash, pulmonary edema, tamponade, and the intense algorithmic violence of a code blue resuscitation.
This depth of understanding is what separates a technician from a clinician. When you walk onto the floor for your clinical rotation tomorrow, you will not just be memorizing tasks. You will look at the swollen ankles, the elevated BMP, the morning dose of lisinopril, and the patient's fatigue, and you will see the entire interconnected physiological puzzle. You are building the foundation of clinical judgment that will save lives.
Before we close out this deep dive, I want to leave you with a profound, sobering thought drawn directly from the final pages of our source text regarding end-of-life care in advanced heart failure. Medicine is incredibly adept at keeping the heart pumping, but eventually the disease process becomes terminal.
Imagine you are caring for a patient with end-stage refractory heart failure. Years ago, they had an implantable cardioverter defibrillator, or ICD, surgically placed in their chest to protect them from lethal dysrhythmias. Now, the medical team and the family have decided to transition to hospice care. The goal is no longer curation. The goal is a peaceful, comfortable, dignified death.
But the technology does not understand the concept of hospice. As the heart naturally and inevitably begins to fail during the dying process, it will slip into lethal dysrhythmias.
The ICD will detect this, interpret it as an emergency, and deliver a massive, violent, incredibly painful electrical shock to the patient's heart. And it will do it again and again, essentially torturing the patient as they attempt to pass away.
Unless a specific, active clinical decision is made to have a technician medically deactivate the shock function of that device, the patient's final moments will be defined by trauma. As the nurse managing that patient's care, you are often the one at the bedside, intimately involved with the family. How do you plan to navigate that deeply emotional, highly complex conversation with a grieving family to ensure they understand the necessity of deactivating the device? How do you ensure your patient's final hours are truly peaceful?
It is a heavy responsibility, and it underscores the profound holistic nature of the care you are preparing to provide.
It is the reality of the profession you've chosen, and it is why this depth of knowledge matters so much. Thank you for dedicating the time to joining us on this deep dive into Chapter 25. We know the pressure you are under. Keep pushing. Trust the knowledge you are building, and we wish you the absolute best of luck on your Week 7 MedSurg exams. We will catch you on the next deep dive.